start recording as well.
Okay, hi everyone. Thanks for joining us. So as you probably know, we're part of BIMA, so British Indian Medical Association. We're a new association, and these lecture series are going to be carrying on throughout the year, and basically trying to fill in the gaps that COVID has left us with, unfortunately. So Rohan, if you can go on to the next slide.
Sure. Sorry, I was getting distracted.
Yeah, that's all right. So my name is Shavini. I'm one of the clinical officers, and Maharsh, you can see his video, is another one of our clinical officers. And we've also got our president, Amar, on the call as well. We're going to be on the call, so if you have any questions, just shoot message in the chat as Rohan's talking, and we'll try our best to answer them. So this is the first cardio lecture that we're doing. It's part 1 of 2. So today's acute, and next Sunday will be chronic cardio, and then we're going to continue on the Gen Med kind of theme for this term, and then more of the specialties in the new year. So I will lead on to Rohan. You can go ahead and start.
I'll start talking. Hey guys, sorry. So my name's Rohan. I am so I've just graduated from UCL this year. I'm currently working as an academic F1 in the east of England. FP is in medical education. So these guys invited me along, and I think so obviously medical education, I just really enjoyed the sound of my own voice, to be perfectly honest with you, I guess. But I really like teaching. So hopefully this is going to be pretty useful for you guys. Just a few sort of ground rules. So I think that if you guys, obviously, if you can switch your microphones off, that would be really appreciative, just so that we don't have any feedback. And in terms of questions, as Javini said, if there are anything, please pop them into the, pop them into the chat, and I'll try and deal with them at the end. I've just found that whenever I've done these sort of things in the past, it just makes sure the flow of the lecture just stays as well, and that's usually I think that's just generally a good thing, because it's, let's be honest, it's 7 p.m. on a Sunday, so we all kind of want to get home and just do our things that we need to do before the week ahead. That's really it. Yeah, so if you guys have got any questions, just make sure you just pop them into the chat, and I'll try and deal with them as we go along. And if there is anything that I can't answer at that time, we've got 2 really good people in Shavini and Maharsh to be able to just go and give things a bit of a Google if we need to. All right, so let's talk about acute cardiology. So this is the first part of our 2-part lecture series into cardio. The next part is going to be chronic cardio. I understand that there's quite a wide range of people that we're going to be that we've got today. So people from different medical schools and also different year groups. What we will do doing is that, obviously, if you fill out the feedback form, we're going to be sending you the lecture slides anyway, and I'm just a bit OCD, so I've just put everything that I talk about into the lecture notes as well. So you know, if there's things that we go over quite quickly that you don't find that you get a good answer when we've answered questions, then you know you're going to get the lecture slides anyway, so don't worry about it. If you are a final year, then this should be really good revision, and if you are a 4th year and you've not seen some of this stuff before, it will just point out some of those key topics that you may otherwise not quite understand as we go through. So in terms of what we're going to be covering, we're going to be covering acute coronary syndromes, tachys, bradys, and a bunch of other stuff. But let's just get into it. I've just got a slide in here about ECGs, and I apologize if this is going to be a little bit patronizing to the people who have covered ECGs before, but I think that definitely when I was in final year and I had just done my specials, I looked at ECGs again and I was actually, I don't remember any of that stuff. So let's just go through and give it a bit of a recap. So ECG stands for electrocardiogram, and it's literally an electronic picture of the heart. So electronic cardio is the heart, and gram, like Instagram, is a picture. I think I really recommend the book ECG Made Easy, because it really breaks things down properly. But as a bit of a sort of cheat sheet, there was a really good picture that these guys found. So essentially, each of the leads of the heart each of the leads on an ECG looks at the heart from different angles. You've got leads 2, 3, and AVF, which are looking at the heart from the bottom, and they're known as your inferior leads. They're looking predominantly at the territory supplied by the right coronary artery. You've got leads 1, AVL, V5, and V6, which are sitting more on this side. And those are the leads usually, that's the area of the heart usually supplied by the left coronary artery. And you've also got the left anterior, so you've also got leads V1 to V4, which are sitting more at the anterior part of the heart, and that's the region supplied by the left anterior descending artery. I think that best thing to do with regards to ECGs. So this is sort of approach and you need to approach your ECG. First of all, like I mentioned, ECG Made Easy is a really good resource, but also Geeky Medics is a fantastic resource and basically where I nicked half of this stuff from in the first place. So the first thing you need to be thinking about with an ECG is firstly, do I have the right patient? Because that's important. And also, why have I done this ECG in the first place? Is this just a checkup ECG, or has this patient got central crushing chest pain and I need to be worried about something going on with this patient and I need to exclude something like a ST elevation myocardial infarction or a heart attack or or an STEMI, which is also a heart attack. And the other thing as well is that I need to exclude I need to take a look at any previous ECGs. The reason why that's important is because you can have changes on an ECG such as what we call things like T-wave inversion, which are signs of ischemia or lack of blood flow to the heart, which can be long-standing. But if you saw that in an acute setting, then you'd be really worried about it. And I've definitely been caught out by that on take when I've panicked over the fact that I've seen some ST depression and T-wave inversion on a patient's ECG, and then the registrar goes to me, actually, Rohan, they're fine, look at a previous ECG, and that's something that's long-standing and we don't need to worry about. So that's the reason why any previous ECGs are important. The way that I was always taught it is rate, rhythm, and axis. So normal heart rate is between 60 and 100 beats per minute. Slower than that is a bradycardia or too slow, and higher than that is a tachycardia or too quick. The rhythm, is it regular or irregular? And if it's irregular, is it regularly irregular or is it irregularly irregular? Because if it's regularly irregular, then that could be a block. If it's irregularly irregular, then that could be something like atrial fibrillation, which hopefully you guys have a vague understanding of what it is. Anyway, so we won't go into too much detail because obviously we could spend a lot of time on things. So if you do feel like we're brushing over topics, make sure you put it in the comments so that we can know when to slow down and when to speed up, because I know we've got a really broad range of people that we're talking to here. The other thing that you need to be thinking about is also axis. So that just means axis is basically where is the electrical activity of the heart mainly? Is it left, right, or is it normal? For your guys' stage, just worry about these three leads here. So 1, 2, and 3. If they're all pointing in the same direction, and that's all pointing up, should we say, and that means that this has got a normal axis. If 1 is pointing up and 2 and 3 are pointing down, then these are called leaving each other. So that's a left axis deviation. And if they're pointing predominantly towards each other, so 1 is pointing down and 2 and 3 are pointing up, then that's known as reaching or a right axis deviation. Then after that, I think to me, it just makes sense to just approach it from the different parts of the ECG. So for example, you'd take a look first at the P waves, which is atrial depolarization. Are they present? That's generally a good thing. If they're not present, then you're worried about something like atrial fibrillation. And you've also got these funny shaped P waves as well. So you've got bifid P waves, or sort of an M shape, or P mitrale, and that's an indication that the mitral that you've got some element of left atrial expansion or enlarging, usually because of a stenotic mitral valve. And I also remembered it because mitrale, and it has this sort of funny M shape as well associated with it. Or it could be just really big or above 2.5 millimeters, and that's known as P pulmonale, and that's because the right side of the heart, the right side of the right atrium is getting a little bit bigger. So those are things that you need to be thinking about. Is there a QRS complex after every P wave? Because that's important. And then after that, you look at the PR interval. So between the P wave and when the QRS complex is going to start. PR interval is usually between 0.12 and 0.2 seconds, or 3 to 5 small squares. If it's smaller than that, then you've got thinking about accessory pathways like your Wolff-Parkinson-White syndrome. So you may have like a slurred upstroke, as it's called on there. Or if it's lengthened, then that means that the conduction from the atria to the ventricles is slowed down. And that's usually an indication of something called heart block, which again, we can cover. Then you look at the QRS complex itself. You want that to be between 2 and 3 small squares, or up to 0.12 milliseconds, or 0.12 seconds, or 120 milliseconds. If it's broader than that, or if it's larger than that, then that means that for some reason that electrical signal going through that ventricle is taking a bit more time. That could be because of one of the bundles or conduction pathways in the ventricles are being blocked, so a bundle branch block, or other parts of the ventricle are taking over as the pacemaker, and therefore the conduction is slowing down. Then after that, you need to look at the ST segment because that's the next part, and the P, Q, R, S, and T pathway of the ECG. If the ST segment is raised, and that's maybe some sign of acute ischemia. If it's depressed, it could be some old ischemia, or it actually could be an N-STEMI or a non-ST elevation MI, or it could also be what's called a reciprocal change, and we'll talk about that in one of the next slides. Then we take a look at the T wave. Are they big and really tall and tented looking? Then that's a sign of of hyperkalemia or hypotassiums, and that's defined as above 5 millimeters in the limb leads, which are 1, 2, 3, AVL, AVF, and AVR, or more than 10 milliliters in your chest leads, which is V1 to V6. And also if they're upside down, then it could be a sign of ischemia as well. So hopefully that's just a quick run through ECGs, just because I wanted to make sure that if you're new to them, then that's the sort of things you need to be looking for. But also if you've not seen them for a while, just a reminder of the kind of things that you need to be looking for when it comes to an ECG. So I like SBAs, so let's go for an SBA. So Mary is a 65-year-old woman who's been admitted to the EAU or emergency assessment unit via A&E with tight chest pain. She has a previous history of hypertension and hypercholesterolemia. Her initial troponin was 35 and the repeat troponin 6 hours later was 48, where normal is less than 13. Her initial ECG was normal, and what is the most likely diagnosis? A is N-STEMI, B is STEMI, C is pericarditis, D is pulmonary embolism, and E is unstable angina. So I'll give you guys about 30 seconds or so to be able to just take a look and see if you can think of answers. You can, I don't know how guys you want to do it. Do you want to put them in the comments section, or do you want to just kind of keep them to yourselves?
I'd say feel free to put them in the comment section.
All right, mate, no worries. So yeah, you can pop them in the comment section, or if you can keep it to yourself, it's completely up to you. No one's being brave. That's absolutely fine. So, hello, we've got some, I think. B, STEMI, Cardiff, nice. B, okay, cool. Yeah, all right. Good sort of thought process. So so far it's between, in our large sample size of 3 people, we've got B's, majority B's, and a few people going for A. So first of all, we need to think about this. So oh God, what have I done? There we go. So I think always when it comes to an SBA, think about a few things. Look at the patient demographic that you've got. You've got a 65-year-old woman, okay, so that's an older sort of patient who's been admitted to the EAU via A&E with tight chest pain, and a tight chest pain is a classic sounding cardiac chest pain, okay? Previous history of hypertension or hypercholesterolemia. As soon as you see high cholesterol, you're thinking that this patient's got plaques which are starting to rupture. So you're thinking, okay, this is either an MI or this is going to be a stroke coming into this picture. Troponins are telling you that this is going to be an MI. Her initial troponin was raised, and then the repeat was also raised. So this is going to be, so she's got she's got T wave, she's got troponins which are raised. So this is now definitely going to be an MI. So automatically your answer is between A and it's between B. Her initial ECG was normal, and now her ECG is showing some ST elevation in V1 to V4, but it's also showing, if you have to look really closely, but there's a W here in V1, and there's an M over here in V6, which is your William, or which is for left bundle branch block. So the W, we'll talk about bundle branch blocks in one of the next slides, but basically the point I was trying to make is new left bundle branch block equals a STEMI. And so if you see this on an ECG and it's new, you're treating it as if this is acute coronary syndrome, and you're going down your STEMI pathway, because this is dangerous. And then just to prove my point, I zoomed in really, really close, and like, can you see the W which is in there and the M which is in there? All right, so this is a STEMI. Most people, I think, got it right there. No worries if you thought it was N-STEMI, because it might be a bit difficult to see the ST elevation. And when we see that, we're looking at the isoelectric baseline, and we're looking to see if the ST part is raised above that baseline, which it is in this particular patient. So this is a STEMI, not only because of the left bundle branch block, but also because you've got your ST elevation here. I hope that's fairly clear. So the reason that other things are wrong, so pericarditis, so this is inflammation of the pericardium, or the stuff around the heart, shows a saddle-shaped ST elevation everywhere. Pulmonary embolism, or a massive clot in the heart. The most, again, past med question, the classic ECG change of a pulmonary embolism is sinus tachycardia, but you can get what's called S1Q3T3, which is deep S waves in S1 and deep Q waves and inverted T waves in lead 3. And the reason why you get that is because the pulmonary embolism is so large that the heart is having to strain itself. The right ventricle is having to strain itself really hard to try and push against it, and it's getting a little bit ischemic, and that's why you're having these ischemic changes with the S1, Q3, and T3, okay? Unstable angina does present with chest pain, but it doesn't have ECG changes, and there isn't a troponin rise. So that's the reason why this is STEMI. And the point I wanted to highlight to you is a new left bundle branch block, because that's not something that I knew necessarily when I was in 4th year when I was starting, until I got caught out with it with a question, all right? So hopefully that is that in terms of SBA 1. If you do have any questions, pop them in the chat and we'll try and answer them as we go through, all right? So let's talk about ischemic heart disease, guys. So it's kind of like it is a spectrum, really. You've got stable angina on one side and you've got STEMI on the other side. Stable angina, so angina is just another name for cardiac chest pain. So really that's defined as cardiac chest pain, which is your classic tightness. Oh, I've got an elephant sitting on my chest, or I've got a really tight chest. And it might be going up to your jaw and it might be going across to your left arm as well. In stable angina, this is exacerbated by exercise, it's relieved within 5 minutes of rest, or it's relieved by taking some GTN spray sublingually, and then that's fine. There's no troponin rise and there's no ECG changes. If that chest pain isn't going away, even with rest and even with GTN, now you're into your acute coronary syndromes. And so you've got the unresolving cardiac chest pain, and now we're into unstable angina, because it's not you're not chilling out, now it's getting a bit more serious. They don't have a troponin rise yet because the level of ischemia isn't that high, and there's no ECG changes for the similar reason. Once you start seeing troponin rises, that's when you're going to your end. Now you've got a myocardial infarction, so this is your end STEMI. But in an end STEMI, by definition, you don't have ST elevation, which you would have when you get to a STEMI. But you could still have ST depression, you could have T wave inversion, or you could have no changes at all. And when it comes to a STEMI, it's ST elevation or a new life bundle branch block are your defining factors for a STEMI. And basically, in the terms of the pathophys, it's classically described as there's a blood clot in the artery, which is becoming more and more ischemic. I think there's a bit of debate as to whether that's exactly the case, but for you guys, just think about it. As you go from left to right, it's just getting a bit worse and the heart isn't getting enough blood supply, all right? The reason why you have the troponin rise, just to get, for those people who like first principles like I do, the ischemia or the lack of blood flow is leading to muscle cell death. And the troponin is just that troponin myosin thing that you remembered from like 1st and 2nd year, like, you know, the troponin myosin coupling crap stuff that happened. So you're looking at a specific type of cardiac troponin called troponin T, which is raised when you've got myocardial cell death. And so as more and more of the muscle dies, that's released into the bloodstream, and that's why you get the rise in the troponins, okay? So I just wanted, the other thing that you can always get asked about is looking at the different regions, as we kind of talked to one of the earliest slides, looking at the different regions and talking about which artery is going to be affected. So I want you guys to have either privately or into the chat, have a think about which artery is affected in this particular ECG. And this is where I'm going to show my age and struggle to use Zoom because I can't figure out how to use the chat. Okay, so I'm assuming people are just so excited that they just kept quiet, but that's fine. So this, oh, hello, we've got one. RCA, brilliant, well done. So yeah, this is a right coronary artery because you've got 2, 3, and AVF, which are all showing varying degrees of ST elevation, and that's a right coronary artery territory. What about this one? Yep, Karishma, well done. That's the LAD, that's the left anterior descending artery. we're going to answer that question in 1 second. And what about this one? Which region is affected now? Let's just change the question slightly. Anterior, anterior, anterior wall. Okay, so this is done. This has had the effect anterior septal. Okay, so this is actually what you're seeing here, which is what you're pointing out. So you're seeing changes here in V2, V3, and V4, but And I can completely understand how that can be confused. That it looks like ST depression. What you're seeing is actually reciprocal changes from the posterior side of the heart. And just to demonstrate that to you, if you were to take that particular region and flip it over, and that's effectively the same as taking these leads here and then looking at them from the back, then you can see this very classic ST elevation in these leads. So that's actually what you need to be doing when you see one of these things and you think, oh, is this a posterior STEMI, or is this a anterior ST depression? Flip it over, and if it looks like a STEMI very classically like this, then you're thinking that actually this is posterior wall infarct, and that's what's going on with this, right? So this is a little bit of a cheat sheet that I kind of collaborated, and I think Mahesh or Shavani, you came up with this really nice, you guys found this really nice picture here, so thank you to you guys. So MM asked the question a little bit earlier about how do I know which leads correspond to which artery. So think about the views that are supplied, right? So the inferior view is by 2, 3, and AVF. So that's the right coronary artery, because if you think about it, just the way I think I'd really recommend reading ECG Made Easy, because it really clarifies this for you. But basically, that's the inferior view of the heart. And because the heart is kind of sitting on the diaphragm like this, that's the region of the heart which is supplied by the right coronary artery, like that, okay? So that's your inferior leads, 2, 3, and AVF. And if you see problems there, then that's your right coronary artery. If it's the lateral leads, which is 2 AVL and V5 and V6, that's your left circumflex. Anterior leads are your V1 to V4, which is the left anterior descending artery. But if you're seeing the ST depression in the way that we saw it beforehand, then that's a V1 and V1 to V3, and you're seeing those reciprocal changes, and that's usually the right coronary artery, but it can also be the left circumflex artery as well. All right, any comments? Don't you need extra leads for posterior wall? Oh, massive MRI, fine. Don't you need extra leads for posterior wall? Yeah, to be able to confirm it, you're absolutely correct. So what they can do is stick some of those leads onto the back of the wall, and then you'll be able to see the ST elevation as you would normally. So that's absolutely correct, Ashim. Good shout for that. So that's, I would recommend taking a little bit of a screenshot perhaps of this screen, because I think that's really useful for you guys. So go ahead and do that, and I'm going to leave it 30 seconds, and then after that we can go ahead. It's not quite 30 seconds, but I'm going to click on it as well. Ooh, chat. Oh, sweet, no worries. Cool, so question number 2. 54-year-old male comes into hospital presenting with central chest pain radiating to the left arm, nausea and profuse sweating. His ECG showed no ST elevation, but his cardiac troponin was 38 nanograms per milliliter on admission and 87 nanograms per milliliter 4 hours later. And normal again is less than 13. His observations are 24. Ooh, sorry. Oh, brilliant. I'm getting distracted by the chat. Sorry, guys. His observations are respiratory rate of 24, oxygen saturations of 95%, and blood pressure of 87/54, heart rate 108, temperature 37. Of the following medications, sorry, my grammar's terrible, of the following medications would be contraindicated in this patient? Morphine, clopy, metoclopramide, GTN, or aspirin? I've got D, I see an E. I'll give it 2-3 more seconds. Well, I'll give it a few more seconds. E. Okay, cool. So again, just because I think it's really important for you guys to understand how to approach an SBA. 52-year-old male, so he's a little bit on the older side, but not too bad. Central chest pain radiating to the left arm is very nausea and profuse sweating. Hopefully you guys are aware that this is presenting with cardiac sounding chest pain. ECG showed no ST elevation, so it's not a STEMI, but his cardiac troponin was 38 and 87 4 hours after that. So his cardiac troponins have gone up, so this is automatically at least an STEMI. You've noticed that his respiratory rate's okay, a little bit high. Oxygen saturation's 94 or 95%, which is fine. Blood pressure is on the low side in this particular patient. Systolic blood pressure is below 90. Heart rate is a little bit up. That would make sense because this patient's having chest pain, and pain will actually pop up your heart rate, but also that the blood pressure is quite low. So the heart is trying to pump a little bit more per minute to be able to maintain blood flow to the rest of the body. So, so just to break those things down a little bit, the thing that I wanted to point your attention to is the fact that this patient's blood pressure is low, and therefore GTN would be contraindicated in this particular patient, at least relatively. And the reason why that's the case is because glycerol triton nitrates, the way that they work, I've got I think I've got somebody's mic on. Glycerol trinitrates, the way that they work is by vasodilation, i.e. they cause the blood vessels to go from this to this, okay? So that works great for the heart in usual people, but in cardiac challenge and chest pain, because that means that the vessels can open up and more blood supply can get to the heart. However, it doesn't do that solely in the coronary circulation. It does that everywhere. So if you were to give this patient GTN, their blood pressure is going to really, really drop, and you could actually shock them. I don't think you're going to do it with GTN 400 micrograms, but it's just something to be aware of, that nitrates are contraindicated when the blood pressure is really low, because you're going to drop that blood pressure even further, and therefore you can potentially prevent perfusion of that person's tissues and organs if you're going ahead and do that. So that's the reason why GTN would be contraindicated in this patient. Ooh, chat. Okay, cool. So hopefully that's a decent explanation for that. So immediate management for all patients who are having acute coronary syndrome. So I always learned this mnemonic MONAC. So that stands for morphine and metoclopramide, 10 milligrams IV, same dose, same route, and they both begin with M. Remember it that way. Oxygen is your next step, only if the saturations are below 94%. If the saturations are above 94%, you do not give oxygen, because actually that oxygen itself is can cause a lot of oxidative stress and further damage if it's given unnecessarily. So that's the reason why you're avoiding oxygen if the saturations are maintained, okay? Nitrates, GTN 400 micrograms sublingually, 2 puffs under the tongue, if not hypertensive. Aspirin of 300 milligrams as a loading dose, and clopidogrel 300 milligrams as well. Some trusts use slightly different doses and slightly different stuff, like ticagrelor and prasugrel and something else, I can't remember. Just allow it. Just remember clopidogrel because it's easy and it forms the mnemonic really nicely. You're not going to be you are not going to be told off in an exam situation, or if you've got a Dr. ABCD OSCE that you're running, given clopidogrel 300 milligrams. That's what we give in my trust. Okay, so that is that. Okay, so that's the immediate management for all patients who've got ACS. This is the next question. So Rose Brown is a 72-year-old female who comes into the hospitals presenting with a 4-hour history of surprise, central crushing chest pain radiating to the left arm, nausea and profuse sweating. So people are trying to join. The person took GTN before coming to the A&E. Would that explain the hypertension to the page? I'm going to leave some of the questions over to the end, guys, because otherwise I'm going to get distracted. All right. So let's just go on with this question. ECG showed no ST elevation, but her troponin was 38 nanograms per milliliter on admission, and that is above normal. You're told that the nearest PCI center is 60 minutes away. Her 6-month mortality risk score is 2.5%, and her observations are stable. After original management, her chest pain was resolved. What is the definitive management of her condition? Alteplase, primary PCI, unfractionated heparin, aspirin, clopidogrel, or bivalirudin? Right, I will give you some time to answer that in the chat. There is no one in the meeting room. Fine. Okay, E, I see. Maharsh, do you want to take a minute to be able to make sure everything's fine? Or are you happy to be able to admit people, etc.? And can I continue?
Yeah. If someone pops up in the waiting room, I'll straight away admit them, but I can't see anything right now. So I was wondering, Nikita, if you mind just checking with your friends just to see if they've got the right link.
Fine, cool. So hopefully, Nikita, that will be sorted from your end. And in the meantime, for everyone else, hopefully you guys have got answers. Sweet, Nikita, thank you for replying. So Hashim's the only one who's been brave enough thus far to put something out. So let's again go through it. So Rose Brown, 72-year-old female, old person, female, okay. 4-hour history of central crushing chest pain, okay. Radiating to the left arm. Again, this sounds like some sort of heart attack. Her ECG showed no ST elevation, but the cardiac troponin was raised. So again, this is at least a STEMI. This is at least a STEMI. This is not a STEMI. This is an MI, but this is an NSTEMI. And you are told that the nearest PCI center is 60 minutes away, and a 6-month mortality score is 2.5%. After original management, which to us would be your MONAC stuff, what is the definitive management of her condition? This answer I've put as aspirin and clopidogrel. And the reason why is because, as most of you have, I think people seem to have alluded to, you're not going to give this patient PCI. First of all, you might give this patient PCI. Sorry, take that back. the reason why it's like this is because the 6-month mortality score is actually really low in this patient, and therefore you don't need to go in to give a PCI for this particular patient. And also the patient doesn't have ST elevation. So you have a few other options that you can use when tackling when you're tackling ACS in terms of definitive management. So alteplase is a clot-busting drug, which you can use for a STEMI, primary PCI or primary percutaneous coronary intervention. What that means is essentially you put a wire, usually through the groin and the femorals, up through into the coronary artery that's causing the trouble and blocked. And then you usually balloon it or you stent it open in terms, so it's a coronary intervention. So you're actually going in and opening that artery, which is closed up and blocked up. So you would do that for STEMIs, and you would do that in someone who's had an NSTEMI with a 6-month mortality score of over 3%, but you wouldn't necessarily, if it's below 3%, it's not that high risk, and actually it won't provide that much benefit. Unfractionated heparin can be given in NSTEMI, and we'll talk about that a little bit later. And bivalirudin, I have no idea what the hell that does. It's just some funky drug that I don't understand, and I just kind of stayed away from, to be honest, my entire time, and I probably recommend you guys do too. So let's talk about definitive management for ACS. So in a STEMI, as we saw before, you're like, crap, this patient's got a blocked artery. I need to go in there and I need to open this patient's artery up. Otherwise, they're going to lose blood supply to like all of that portion of the heart, and they're going to die. Maharsh, I think your microphone's on, buddy. Okay, that's fine. All right, I think you're going to die. Therefore, you want to try and open that artery up in some way or form. If you're within 120 minutes of a cath lab, so you're within 2 hours on a cath lab, or you're within 12 hours of the symptoms starting, what you're going to do is send them to that cath lab or that PCI center so that they can get that artery opened up. If they are more than 2 hours away from a cath lab, but the symptoms have started less than 12 hours ago, then there's not enough time to get them to the cath lab. So you're going to try and use fibrinolysis or clot busting to open up that clot. And after you do that, you need to make sure that you repeat the ECG about 60 minutes after to make sure it's worked. If it hasn't, if the way that you would know if it had worked or not is if there's ST elevation still present. If it's still present, it's not worked, and then therefore, it'll take as long as it'll take, but you take them to the cath lab for them to open up that artery. If you are outside the 2 hour cath lab, actually, this slide should read, if you are outside 12 hours since symptoms started, so say the symptoms started 13 hours ago, you're actually beyond the time when going to a PCI center or fibrinolysis will probably be useful for this patient. The only patients that you would take to the PCI center is if they've got an element of cardiogenic shock, because in that case, you are so desperate to try and give this guy some help, or this guy or this girl some level of help, that you're going to send them to the PCI center just so that maybe there's a 1 in 100 chance of being able to open up that artery. But realistically, it's likely that you're not going to be very successful if you try and do that, which is why it's only indicated if the patient's in cardiogenic shock. Okay? So that's what you do, how you deal with STEMI. NSTEMI, or unstable angina. So the first thing that you're going to do after you've done your MONAC is you're going to risk stratify using something called a GRACE score. And that will stratify things into a low, intermediate, or a high risk. Really, you just need to worry about if they're low risk or if they're intermediate or above. Low risk is defined as less than 3% 6-month mortality. And in this case, you go for no PCI and you just stick with conservative management. Well, you stick with medical management for these particular patients. If they're intermediate or higher risk, so above 3% 6-month mortality, then you're going to be sending them off for PCI. But you're not as desperate because they don't have a STEMI, they have an NSTEMI, okay? So you can PCI them whenever you can get round to PCIing them, basically. If that's going to happen within 96 hours or 4 days and their renal function's all right, then you can use fondaparinux. And fondaparinux is another blood thinning medication, which you can just use to thin the blood so that they don't develop another clot somewhere. However, if you're told that you're going to have the PCI within a day, or if they've got renal impairment, then you'd go for unfractionated heparin instead of that. Is that all right? I can see some questions popping up in the chat. If it's been above 12 hours, but they aren't in cardiogenic shock, what do you do? From what it seems like, you would just go to the normal sort of management and be like, actually, this patient's, from what I understood of reading of the guidelines, and obviously if you get told something different when you're on the wards, go for that, is that actually you're probably not going to PCI them, and you're probably just going to stick with definitive management. That's how I understand it. But actually, if if Shavini or Maharsh, if you take a quick Google of that, just to make sure that I'm not telling people any lies, then that'd be fantastic if you could take a look. Is that all right? Sweet, thanks, mate. But that's why I understand it from reading the guidelines. But it wasn't too clear, is the honest answer about that. Okay. So that's STEMI and that's end-STEMI. Cool. So long-term management post-STEMI. So what I did was I had this mnemonic, which was BADS, so B-A-D-S, for what you would do after a STEMI. B stood for beta blocker, which was bisoprolol, usually something like bisoprolol. ACE inhibitor or an ARB, such as ramipril or losartan if it's an ARB. And then dual antiplatelet therapy, which is aspirin for 75 milligrams for the rest of their life, plus something else for a year. So that can be clopidogrel, prasugrel, ticagrelor. I just remembered clopidogrel 75 milligrams because it's the same dose as aspirin. The only thing to note is that you're giving that just for a year, and then after that you would stop it. And then finally, the final bit of the mnemonic is a statin, usually a atorvastatin at an 80 milligram dose. And that's given at night because it can cause some muscle pain. And you want to just, if when they're asleep, they're not going to notice it, but when they're awake, they're going to notice it. And that's the reason why you give a atorvastatin at night. The other thing that I think somebody managed to pop up with is if they've got left ventricular systolic dysfunction, or if they've got some element of heart failure, then you could be adding in some spironolactone as well, but you'd start that a few days after, and that would just help. And it's got some prognostic benefit, I believe. Let's make sure there's no questions. Do you have any tips for learning doses like MG? What would you replace aspirin with for asthmatic patients? Not too sure with that one actually, because I know that aspirin can actually cause some sort of problems with you've got asthmatic patients, but what you would actually use, I'm not sure. I've not been faced with that scenario. I think in terms of how it matters for you guys, I think it'd be very mean for them to come up with something like that. I would imagine that they would either go for maybe this is just me speculating, probably they'd go for a single agent with, say, for example, clopidogrel, or they may decide to use clopidogrel and ticagrelor, but this is me speculating. So for you guys, I would just remember the aspirin and the clopidogrel for patients with a STEMI. It's very unlikely that in medical school they'll give you people with multiple different comorbidities. Okay, so Maharsh says give clopidogrel or similar alone. So there you go. That's what one of the things that I was thinking about. So Prathana, you asked about how do you have any tips for learning doses like milligrams? So what I would say for that is I use this app called Anki, which is the flashcard app. And I found that really good for just drilling things like my doctorate. So I would just make those flashcards and I would just drill those. And if there was like little mnemonics here and there that I could remember or people taught me, then that's fantastic and I would go for that. But really it is about, for me, it was just about working fairly hard actually, unfortunately, and trying to ram that into my brain. But I think that Anki is a really good and efficient way of doing that. So I'm a very big advocate. If anyone knows me and have listened to me talking about Anki, then they know I'm a big advocate of it. So yeah, that's my advice for that. No worries, mate. Cool. So MI complications. So this is your maybe your higher level SBA things that you may get. So just this is like SBA topics, SBA sort of questions or stems that I thought you should be aware of. Shout out to, there's a guy called Adam Ali who taught us in 4th year. He was fantastic, and actually, so some of the stuff is from his slides, and he's really, really good. And I basically was just taking some of the stuff from he put in that he had talked about and put it into my lecture as well because it was really useful. So structural changes include things like a ventricular aneurysm. So basically the ventricle ballooning out, and the classic history is that this patient has had an MI 4 weeks ago and he's got an ST elevation in leads 2, 3 and AVF. So it's a consistent ST elevation in that particular part. And then what do you think is going on? And the answer is actually ventricular aneurysm in that patient. You can also have mitral regurgitation or other forms of valve regurgitation because the papillary muscles which hold that valve into place, if you've got the bit of the heart that's supplying that particular muscle or tendon holding it in place, and that's the bit of heart that goes, then that papillary muscle can actually rupture, and therefore you can get a new onset murmur from that. So again, if you've got a new onset murmur following an MI, it's usually because of a papillary muscle rupture. Okay, so that's another sort of thing that you might want to remember for SBAs. Arrhythmias, so bundle blocks, fibrose bundles. So just to remind you about everything, structure of conduction in the heart, you've got your sinoatrial node, then that sends depolarizations around the atria. Then that goes to the AVN or the atrioventricular nodes, which holds it in place a little bit to allow the blood from the atria to flow into the ventricles. Holds it a little bit, and then they send they send conduction through what's called the bundles, which you've got a left bundle and you've got a right bundle. I think you've actually got two right bundles, but ignore that point. You've got bundles, which are essentially like fast conduction motorways of conduction from the AVN to the rest of the ventricle, and then that allows you to depolarize the ventricles very, very quickly. If one of those bundles gets blocked because of the fibrosis that occurs after you've had a heart attack, then you couldn't get a bundle branch block appearing on the ECG. You can also get other tachycardias, other arrhythmias like VT or VF, and also you can get a bradycardia. So right coronary artery, one of the things that it supplies is actually the sinoatrial node itself. If the right coronary artery is infarcted, then effectively you've infarcted and damaged the sinoatrial node, so it can't fire as well as it could, or actually other parts of the heart actually take over as a pacemaker. So if you've got a patient who previously was, running at about 70 BPM, they've had a heart attack, it's an inferior MI, so it's a right coronary artery MI, and now they're running at 40. Why is the reason? It's because their sinoatrial node has been affected. Okay, so that's bradycardias. Heart failure, yeah, cardiogenic shock. Yeah, exactly. If you think about it, if your heart muscle is screwed up, then it's not going to be able to pump as well, and therefore you're going to get heart failure. That makes a lot of sense. And also this autoimmune condition called Dressler syndrome can develop, and that's a autoimmune derived pericarditis. So the reason why that happens is because when you've got the MI which is happening, you've got the death of all of that muscle which is within that, right? So bits of cells that the body doesn't really usually see get sent out into the bloodstream, and actually it thinks it's foreign, so it kind of goes ahead and attacks it. Again, this is only in a small minority of patients, but this is the pathophysiology behind Dressler syndrome. So it decides to attack it, and then it develops autoantibodies against it, and then after that they start attacking the pericardium, all that like tissue around the heart, and that causes your pericarditis or inflammation of the pericardium. That's classical history is this dude's had an MI about 3 weeks ago or 2 weeks ago in this example, and now he's got chest pain, which he describes as being pleuritic, i.e. worse when he breathes in, but it's relieved upon sitting forward. What is the pathogenesis? What is the condition? Is it pericarditis? Is it Dressler syndrome? Is it another MI? And the answer is Dressler syndrome. And again, you see a global ST-shaped, saddle-shaped ST elevation in that picture. All right. So those are some of those classic SBAs that other people may not, or classic complications of MIs that are very SBA-able, and I would definitely recommend knowing. Okay. So SBA 4, you're asked to urgently review a 64-year-old male at 64, God, my grammar is atrocious, I'm sorry, on the cardiology ward due to difficulty breathing. He has bilateral fine crackles to the midzones and a raised JVP on examination, and ECG shows the following. What is the most appropriate management? Okay. Urgent DC cardioversion, digoxin, amiodarone, or magnesium sulfate. Ooh, chat. Oh, I accidentally clicked it. Nice. Well done. So first of all, just again, looking at the SBA, 64-year-old male on the cardiology ward. Instantly, we're worried. Difficulty breathing, okay. Is bilateral fine crackles to the midzones and a raised JVP on examination. So now we know that this patient's decompensating, right? And the ECG shows the following, which is an AF, which is running pretty quickly. So this is a narrow complex tachycardia, and they are shocked, and they've got signs of shock. You are going to shock them, okay? That's what you're going to do. You're going to DC cardiovert them, which is, the answer is A, which a lot of you got already, so well done. Digoxin, amiodarone, and magnesium sulfate are potentially, well, not really digoxin, but amiodarone and magnesium sulfate could be used in particular on some particular algorithms, but we'll talk about that a little bit later, okay? 75-year-old woman, history of asthma, presents with palpitations that started just over an hour ago. Regular tachycardia of 180 beats per minute, QRS duration 100 milliseconds. No other symptoms, sats 98% from room air. Perform the Valsalva maneuver multiple times, the rhythm remains the same. What's the next most appropriate step? DC cardiovert, IV adenosine, reattempt the Valsalva, amiodarone, or verapamil. BB. D. One or two more people. Okay, so the answer here is, oh crap, hang on. So the thing that I need to point out here is that this patient has got a history of asthma, okay? And if a patient's got asthma, you cannot give adenosine because it causes bronchospasm and can cause yeah, it's not a good thing to do basically with patients who've got a history of asthma. So again, 75-year-old woman, history of asthma. They've told you that for a reason. Make sure you understand that. Palpitations, okay. Hour ago, fine. She's running high, so she's tachycardic, and QRS duration is 100 milliseconds. So she's got a narrow complex tachycardia, because remember, a usual QRS complex is about 80 to 120 milliseconds. She's otherwise fine, sats are fine. The Valsalva maneuver has been performed, but the rhythm remains the same. That's basically telling you that you've tried the Valsalva, it's not worked, do something different, doctor, okay? So DC cardioversion would not be indicated because this patient doesn't have any adverse features. IV adenosine would be the next option if the patient didn't have a history of asthma, okay? But they do, so you can't use IV adenosine. You have to use verapamil instead. Reattempt the Valsalva. You've tried this before, it's not worked, do something different. And IV amiodarone, you wouldn't use a narrow complex tachycardia unless you've DC cardioverted them before, and I'll go through the algorithm in the next slides. So the answer here is verapamil, okay? So that is that. So let's talk about tachys. So narrow complex tachycardia is going to be the first thing that we're going to talk about. Basically, if they look like crap, you shock them. So if they are hemodynamically unstable, so they've got, a systolic blood pressure below 90, you shock them. If they're if they've got syncope, or they are not, they're fainting, that means that they're not perfusing their brain properly, so you shock them. If they've got indications that actually this is leading to them having a heart attack or heart failure as well, there's a problem that the narrow complex tachycardia is causing. So you have to shock the tachycardia to try and reset that heart back into a normal sinus rhythm, okay? So you DC cardio at them first, and then you give amiodarone as a 300 milligram bolus over roughly 20 minutes. And then after that, you give 900 milligrams over the next 24 hours, okay? So if they're shocked, you shock them. Or if they look like crap, actually, that's when you shock them. If they don't have any adverse features, then you can try your vagal maneuvers, and you've got various different options of that. You've got the carotid sinus massage, the Valsalva maneuver, which is usually blowing into a syringe, or actually you can stick their head in a bucket of ice, though I wouldn't recommend that being your first line choice. But apparently it's a very good way of triggering that vagal response to then have a massive parasympathetic effect on the heart and slow that heart rate down. All right, so that's your first options. If they're not working, then you're going to go for adenosine, and the doses are 6 milligrams. And then if that's not working, 12 milligrams, and if that's not working, another 12 milligrams. And if none of that is working, you're going to need to go to an expert. The only time you're not going to give adenosine is usually in things like asthma. And then after that, you go for the IV verapamil instead. And I just stole this, by the way, guys, from the emergency section at the back of the Oxford Handbook. So I'd really recommend you give that a read if you've not discovered it before. All right. SBA 6. So just make sure there's no questions on that. I think we're good. SBA 6, a 48-year-old, what have I done? Oh, crap. A 48-year-old woman, I just showed you a 48-year-old woman with type 2 diabetes presents with palpitations for the last 3 days and irregular pulse. Her BP is 110/57, heart rate 76, and the temperature is 36.7. What's the most important next management step? DC cardio, apixaban, and then DC cardioversion in 3 weeks. Apixaban and bisoprolol long term, chemical cardioversion of flecainide now, or apixaban and then chemical cardioversion in 3 weeks. So you guys, I know that I accidentally clicked it, so you guys have probably already seen the answer, but it should be B, correct. So the reason why, again, 48-year-old woman, always take a look at the demographic and the person who it is, yeah? Presents with palpitations for the last 3 days. So they've had at least 72 hours worth of these palpitations and an irregular pulse, which tells you that this patient's got atrial fibrillation. They're generally all right because the heart rate's all right, blood pressure's all right, breast rate's all right, oxygen's all right, temperature's okay. And they've got a recent onset, they've had a recent onset of AF. So we'll talk about how you manage acute AF in a second, but basically the correct answer is to anticoagulate for 3 weeks and then DC cardiovert them after that is over. All right. You wouldn't DC cardio, but the risk with AF, so most of you are probably aware of this already, but if you're not, atrial fibrillation is when the atria are essentially doing this. Okay, they're not really pushing blood around very well. And therefore some blood can kind of stay there and becomes really stagnant and can actually clot. If you were to DC, if you were to shock them right now and push that into a normal rhythm, then you risk that clot breaking off and then going into the lungs and causing a pulmonary embolism, or going into the brain and causing a stroke. So If the symptoms have started and you're sure that they have started in the last 48 hours, then it's not enough time for that clot to be able to form. But if you're unsure, or if it's beyond that 48 hours, then that clot's probably there, and you have to make sure you get rid of that by anticoagulating them before you can then shock them back into a normal rhythm. Okay, so DQC cardioversion now is inappropriate because you need 48 hours of anticoagulation. Apixaban and bisoprolol long term. So a rate controlling of this patient is probably not the best thing, because actually they're quite young, and also they've only had new onset symptoms. So actually I think you'd be fine to be able to actually try and put them into a normal sinus rhythm. And chemical cardioversion is with flecainide now. So again, you need to wait more than 48 hours. You need to wait for the 3 weeks of anticoagulation. And the reason why you go for chemical DC cardioversion above chemical cardioversion is because NICE prefer electrical cardioversion when you're having to recoagulate them, recardioverse them like this. So it was a bit complicated, but we'll talk you through atrial fibrillation. So what's going on in atrial fibrillation, right? I like first principles. So usually, as we described before, when the heart's beating, you go from the sinoatrial node, you send an impulse which goes to the rest of the atria. They contract really nicely, and then the blood goes, and then the blood goes to the ventricles, and the electrical signal is going from the AVN down the bundles, around the ventricles, and then contracting. In atrial fibrillation, all these different parts of the atria are trying to take over the role of the sinoatrial node and trying to be the pacemaker, okay? And so occasionally, and because of that, you don't have a really nice contraction taking place, and therefore you don't get the really nice P wave appearing on the ECG. And occasionally one of these excitations will actually end up making its way over to the AVN and actually causing a QRS complex to form. But the way that it does that is really random, and there's no way really of predicting it, which is why you have this irregular pulse. Okay, so that's the reason why you have an irregular pulse, and also why you don't have any P waves when it comes to atrial fibrillation. You've got a few different types. So paroxysmal AF is when you had more than 2 episodes, usually less than 24 hours in length, which terminate by themselves without needing any chemical cardioversion, for example. Persistent AF is ones that last for more than 2 episodes, which don't terminate without some sort of intervention. And permanent AF is when you can't be cardioverted. So even after they've shocked them, even after they've given some flecainide, etc., they can't go back into a normal rhythm, and it's just permanent. All right. Reason why you can get it. So some people just get it because they're old. So 10% of over 80s actually have AF. But also things like infection, structural disease from like a heart attack, or even high thyroid, an overactive thyroid can all cause you to have atrial fibrillation. And clinical features include things like palpitations, blackouts, and chest pain. All right. Investigations, really the main one in this is the ECG. You need to be able to actually see that AF taking place. So if you don't see it if this patient has palpitations and they say they come intermittently, and this could be a paroxysmal AF, right, random intermittent periods. So if you don't see it on that patient's emitting ECG, then you might need to send them for a 24-hour tape to be able to actually have a look and see whether they have it. And usually they have a little button which they can say, oh, I'm having a palpitation, and see if that button, when they press the button, coincides when they're actually going into AF. And again, a regular rhythm and no P waves. That's how you define it, okay? Management-wise, you're looking at rate and rhythm control. So NICE prefer rate control in most patients. When you usually use beta blockers or diltiazem and verapamil, unless they've got coexisting heart failure, it's new onset, or there's an obvious reversible cause, and in which case you would try and if it's a reversible cause, you try and fix the reversible cause, or if it's coexisting heart failure, if it's new onset, you would try rhythm control, or trying to put them back into a normal sinus rhythm. Just as a sort of just a funny little aid memoir. I always used to get confused. So you've got, most of you probably know about calcium channel blockers, right? You've got diltiazem, verapamil, as well as things like amlodipine, right? And there was always a bit of confusion as to which ones are used for which. So the way that my mate taught me it is that the penes act peripherally. So I think that's what you use generally in hypertension. Please correct me if I'm wrong, I've not realized that. So that's why you go for the penes. And very nicely that verapamil and diltiazem are like Dilmil, like there's like this Indian dating app, which you guys probably are aware of, called Dilmil. And they are cardioselective calcium channel blockers. So it's Dilmil for the heart, diltiazem and verapamil. So I thought it was a really useful way of learning it. In addition, the other thing as well to mention is that if you've got paroxysmal AF, and they're otherwise well, i.e. I occasionally get these palpitations. When I get them, I can see that my heart's going into AF, but actually I'm absolutely fine. I just have these funny palpitations, doctor. You can try the pill in pocket, which is just some flecainide that they would take when they're having those particular episodes. All right, so usually they rate control them unless they've got these things, in which case you try and rhythm control them. If it's paroxysmal and they're otherwise well, then you try the pill in pocket. You're also wanting to worry about atrial fibrillation and the risks of stroke. So you're kind of thinking about anticoagulation, and therefore you're going to do your CHADS-VASc score, and if it's 2 or more, then you would give anticoagulation. All righty, and that's the CHADS-VASc score just appearing up at this side. Very easy to Google and take a look. Cool. Cool. So just to go a little bit more into detail about the different methods of rhythm control, if it's AF of less than 48 hours, you can electrically cardiovert, so you would sedate them and then shock them, or you can chemically cardiovert using either flecainide or amiodarone. If they've got some structural heart disease, i.e. they've got valve problems, you can see ischemic changes on the ECG, or they've got something like HOCM, you can't use flecainide, so you have to go for amiodarone. And again, that's a classic SBA question. Had this patient less than 48 hours, which medication do I give them to be able to cardiovert them? Do I go flecainide? Oh, by the way, they've got this ECG, which shows T-wave inversion. Do I give flecainide, amiodarone, bisoprolol, la 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 la? The answer is you give amiodarone because they've got some evidence of ischemic heart disease or structural heart disease, all right? If you're above 48 hours or you're unsure, then you would prefer doing electronic cardioversion, but you need to wait the 3 weeks and then cardiovert them because you're worried about that clot, which you're then going to send off, which is probably developed into there. I also saw this thing on PassMed about the other thing is that if sometimes you can perform a transesophageal echocardiogram to take a look and see if there's a thrombus in the atria. And if that comes back clear, then you can actually cardiovert them without having to wait the 3 weeks. I've only seen that on PassMed though. I've not seen that in the NICE guidance specifically, but it's just something worth bearing in mind that I've put in there, but with the caveat that I've not seen that on the NICE guidelines, but just to let you know that that may be something that you may come across. Is that all right? Ooh, chat. Dill mill lol. Yeah, I know, Bants, innit? They're funny. I thought it was absolutely hilarious. Shout out Vicious Motka, doctor. Right, moving on. So, atrial flutter. Oh yeah, this is just another funny rhythm. So this is the sawtooth appearance, kind of classic rhythm of atrial flutter. It looks like a sawtooth. Basically, you manage that really by cardioverting or trying to get rid of the isthmus that's causing this, getting rid of the bit of the thing that's actually causing the problem. I think from what I understand, it's actually treated very similarly to AF. So basically try and shock them into a normal rhythm. But the difference is that you've got these P waves, but it's this weird sawtooth pattern, and it's very recognizable when you take a look at an ECG. Okay. SBA number 7, 60-year-old woman, history of ischemic heart disease, presents with this ECG and palpitations, no dizziness, chest pain or clamminess, and her blood pressure is 120/76. What's the first line management for this patient? Adenosine, amiodarone, sotalol, verapamil, or bisoprolol? Just waiting for the comment section to pop up. Karishma, well done for being brave. Okay, good. So this patient's got ischemic heart disease, fine. Presents with this ECG. So this is showing a regular, broad complex tachycardia, because this is above the 3 small squares, so it's broad and it is regular. No dizziness, chest pain, or clamminess, blood pressure is okay. So she doesn't have any other problems apart from the fact that she's got this tachycardia and it's broad complex. The answer correctly, as given by at least one person, is amiodarone in this particular patient. Adenosine is what you would give in the narrow complex tachycardias, which is what we saw before. Sotalol and bisoprolol are beta blockers. You wouldn't really be giving that in this particular patient. And verapamil, again, is something that you'd use for narrow complex tachycardias. So well done. This is amiodarone. Let's talk about broad complex tachys. So again, you can see that I've very easily stolen this from the Oxford Handbook of Clinical Medicine because it talks about things really well. So if you've got a patient with a broad complex tachycardia, the first thing, or even, to be honest, any sort of heart rhythm, first thing you need to check is, do they have a pulse? If they have a pulse, if they don't have a pulse, they're in cardiac arrest. So you need to start jumping up and down in the chest, all right? If they do have a pulse, then think about giving oxygen, get IV access, and then check if they've got any adverse features. So again, that's the same as before. Are they shocked? Do they have chest pain or ischemia or an ECG? Are they heart failure, or do they have syncope? If they have any of those things, then they need to be cardioverted into the correct rhythm. So you need to shock them. All right, same as you would with narrow complex tachycardias. Adverse signs, you shock them. So you sedate them, give up to 3 shocks, and then you would give some amiodarone after that, 300 milligrams over 20 minutes, and then 900 milligrams over 24 hours. And you'd go that way. If they don't have any adverse features, you need to decide, is this a regular broad complex tachycardia? And if it is, then you would give amiodarone as correctly described in the previous example. Or is it irregular? And if it's irregular, then you're a bit stuck. You've got some other options, basically it could either be Torsade de Pointe, with butchering the pronunciation of that, by the way, I'm really sorry. But whatever, hey, we'll see what that looks like in a second, but you would give 2 grams of IV magnesium sulfate in that particular patient. Or it could be an AF with a bundle branch block, and then after, if you did that, you would treat AF. Or it could be this other thing, pre-excited AF and all of that stuff. But really, as soon as you see it's an irregular broad complex tachycardia, you're going to be calling your med. To be honest, as soon as you see that this on the ECG and the fact that they're in trouble, you're going to be calling a med reg at this point, realistically, as an F1. But basically, like, according to the algorithm, you need to be calling your expert at this particular stage. And if they're a regular tachycardia, then you would manage it and then call the med reg. If none of that is working, then you would sedate and then you would shock them. All right. So again, if it's regular, amiodarone; irregular, and Torsade de Pointe, magnesium sulfate; AF with irregularly irregular with the broad complexes, then treat as an AF. If none of that's working, then you shock them. Cool. So just to show you what all of those things look like. So the ventricular tachycardia is a regular broad complex tachycardia. Okay. So that's looks like this, and yeah, that's what it looks like. It's regular, it's broad complex, that's a VT. Torsade de Pointe is the turning of the points, and you can see how this looks like I don't even know, like a ribbon which has been twisted around a few things, right? Twisted around a few times, or like a DNA double helix. It's kind of like going like this in this sort of sinusoidal funky pattern. And that's classic Torsade de Pointe, or someone, I don't know, I'm not even going to try and pronounce that again because I'm butchering it. But anyway, the other thing that you could get is when it just looks like a funny little squiggle and a bit of a mess. This is ventricular fibrillation. You will never have a pulse with this because there's no coordinated contraction of the ventricles. So therefore, this is one of your shockable rhythms in the ALS algorithm. And this is what an atrial fibrillation with bundle branch block looks like. So again, they've got a, so here you can see that the bundle branch block is a right bundle branch block here in V1 and V2. But you can see that it's irregularly irregular, okay? So it is broad complex, it is tachycardic, but because you can see that you've got like elements where it's irregularly irregular, actually this is more likely an AF with bundle branch block rather than any of the other things. All right. So SBA 8, 40-year-old, question. Do you shock VT with a pulse? No. You would treat them with amiodarone as you would do before. Good question though. Well, hang on, actually, let me clarify that. If they have adverse features, then you would shock them. If they don't have adverse features, then you don't need to shock them. But I think you're referring to the ALS algorithm, and we'll talk about that on the next slides. SBA 8. So a 40-year-old man presents to A&E with shortness of breath, with difficulty, tells you to start on a new medication by his GP. Which medication was he prescribed? Erythromycin, spironolactone, amoxicillin, warfarin, and ibuprofen. Okay, so I see a B. B as well, yeah, B. Okay, B, fine. So this answer is A, because erythromycin is a known precipitant. So basically here, you're seeing the ECG, and you're seeing that this is the rhythm strip, it's all going along normally, and then you're starting to see the sinusoidal pattern, which is the Torsade de Pointe thing, right? So this patient's going into TDP. And the reason why they're going into it is because you've got erythromycin, which is a known TDP precipitant. Spironolactone is potassium-sparing diuretic, so it can raise the potassium levels, but it's not hyperkalemia that precipitates, QTc prolongation. It's hypokalemia, which precipitates it, so that can't be spiro. Amoxicillin, warfarin, ibuprofen, absolutely fine. But the main thing was just to know about erythromycin. And there's a few, how does erythromycin precipitate TDP? It prolongs a QTc interval, interval, exactly the mechanism I don't know, but that's the reason why. there is a really good list on PassMed of all of the drugs that can precipitate it. This is a bit more niche knowledge. I wouldn't waste my time really learning this unless you know everything else, but it's just something to kind of just shock you a little bit and hopefully keep your attention going. Other things that can cause a prolonged QT, so it can be a congenital thing. There's various different medications, tricyclic antidepressants, fluoxetine, chloroquine, macrolides, including erythromycin, electrolyte abnormalities, so low stuff here, MI, myocarditis, hypothermia, Screenshot that, learn that in your own time. There's not an easy way of remembering this, to be honest, and it's a bit of effort. I don't think it's worth the mark, but it's just a nice, if you're wanting to gun, then go for it. And that's a little cheeky question there. Is that all right? Okay. So it's SBA 9. A 45-year-old tall, thin man comes into A&E with an episode of tearing chest pain that radiates through to the back. He has a history of hypertension and Marfan syndrome, and a CTPA is performed and shows the following, which is this picture, by the way. BP is 115/87. What's the definitive management? Cardiothoracic surgery, ACE inhibitor, monitor, IV labetalol, aspirin, and clopidogrel. Oh, everyone's popping up now. Okay, cool. So I'm seeing a lot of A's. So let's just go through this, yeah? Again, how do I approach SBAs? A 45-year-old gentleman, so fairly on the young side. He's tall and thin, right. So this in SBA land means that this patient has got Marfan syndrome, which is a congenital connective tissue abnormality, right? So tall, thin, especially male, Marfan's you should really be thinking about. I think there's also a condition like, I think it's Turner's syndrome that can also cause a similar appearance. Someone's going to hopefully pop up and correct me on that. But yeah, just something to be aware of. And they have tearing chest pain. Now that's important because tearing chest pain is the classic description of an aortic dissection, and especially one that radiates through to the back. History of hypertension or high blood pressure increases your risk of dissection, and Marfan syndrome, they've basically confirmed to you that this patient's got Marfan's. CTPA performed, I've just clicked the next slide. I'm really bad at this. It shows the following, and the following that's meant to show is that you've got this funny looking thing going up in the ascending aorta, right? Just to highlight a few things. So that's the front, that's the back, which is always useful. This is left and this is right. Helpfully, L and R is demarcated here. Okay, this is the pulmonary vasculature up here, and this is your ascending aorta, and this is your descending aorta. And can you see here that instead of it being a nice nice homogeneous like color the entire way through, you've actually got this funny line in here and these two chambers which are both filled with this weird stuff. This is blood, and this is probably a bit of blood and some random stuff. And this is basically the tunica intima having dissected itself away, hence dissection, from the medial layer in the ascending aorta. And if it's an ascending aorta that's affected, you need to go in with cardiothoracic surgery to be able to correct that abnormality, okay? Because it's a really dangerous thing to do. ACE inhibitor, no. Monitor, are you joking? Yeah, I just wasn't impressed. I was like, nah, you're not going to monitor this. IV labetalol is what you would use potentially for IV labetalol and conservative management is what you would use potentially for a descending aortic dissection. So one on this side of the things, but not an ascending one. And aspirin clopidogrel is what you'd use for a myocardial infarction. So let's talk about aortic dissection. So as I just said before, it's a tear in the tunica intima of the wall of the aorta. And what happens is that a little layer is having a bit of a tear in it. Blood finds its way into it has a little flap that's opened up. Blood finds its way and it's forced its way through, and then therefore it's dissecting itself from the tunica media layer, which is sitting below it. All right. It's associated with conditions like hypertension, Marfan's, Ehlers-Danlos, Turner syndrome, and a bicuspid aortic valve. So again, Marfan's and Ehlers-Danlos connective tissue syndromes. Turner syndrome, I think tall, thin male, and also they've got association with bicuspid aortic valve. And again, this all increases your risk of developing an aortic dissection. My point being is that if you see this in an SBA, be thinking of this, especially with chest pain, be thinking of this in terms of differentials, okay? The classification that we use is this Stanford classification. So if it's a type A aortic dissection, then it involves the ascending aorta, A for ascending, which is the bit from the heart to the aortic arch. And if it's a type B, then it's involving the descending aorta, which is the bit from the aortic arch downwards. All right. It's described as a severe tearing chest pain radiating through to the back, and you can also have elements of aortic regurg and hypertension. We also risk in a type A is inferior myocardial infarction and also neurological signs. The reason why is because that dissection can extend its way down into the coronary arteries and actually cause dissection and therefore occlusion of those particular arteries as well, which will obviously impede blood flow and cause your myocardial infarction. It can cause neurological signs because if it affects the blood supply going from the aortic arch through to the brains through the, I want to say, carotid arteries. Yeah, carotid arteries. I think there's a subclavian in there, something I made second year was long ago. I don't remember this anatomy. But basically it affects the blood supply going up to the brain, and therefore you could have neurological signs associated with it as well. And the type B can be associated with AKI just because you've got impediment of the blood flow going down to the renal arteries, which are coming off around this side, halfway down the abdominal aorta. If the ascending aorta is involved in any way, then you are really worried because it can cause the myocardial infarction or you can cause a neurological problem. So you're going to have a surgical management probably by just going in there and actually just holding the thing in place. I'm not sure exactly which surgery that they use. I know that they can either go through the groin or they endovascular, or they can use sort of open heart surgery to be able to open it up. But I assume they just pack the aneurysm into place. But again, if someone can confirm that, that'd be awesome. But if it's a type B, then we're not as worried about it. And so you would just use conservative management and maybe use labetalol to control the blood pressure and just keep it down. I see the chat opening up. Wasn't it Ehlers-Danlos syndrome? So it was Marfan syndrome. Ehlers-Danlos is like the really stretchy joints where they can do all kinds of crazy stuff with that. That's the classic description of Ehlers-Danlos, as far as I remember anyway. But if I'm wrong, I'll put my hands up and admit to it. And if anyone can correct that, that would be fantastic. But I'm pretty certain it was I'm pretty certain it was Marfan syndrome, where the tall, thin male is classically Marfan's. Okay, so we're going to move on. 32-year-old marathon runner comes into the GP practice for a checkup. He has no significant past medical history. His observations were as follows: with a respiratory rate of 12, heart rate of 44, BP of 102 over 78, oxygen stats of 100%, and temperature of 37.0. The ECG strip is shown below. What is the most appropriate management of this patient? Pacing, adenosine, observing, isopranolone, or DC cardioversion? A. Okay. Okay, so people have voted, majority of people there have gone for A. So he's a 32-year-old marathon runner, okay? And automatically, when they say something like this, that means that this patient is really, really fit, okay? That means that they've got a really good reserve. And they've come into the GP practice for a checkup. They've not come in because they've got chest pain. They're not coming into A&E. It's because they're just coming in and they're just chilling around. I see a C, okay. And they're just chilling around. He's got no significant past medical history. And his observations show a normal rest rate, a heart rate which is low, a blood pressure which is a little bit on the low side, but fairly normal, especially for a young dude who's a marathon runner. Perfect oxygen saturations, perfect temperature, and the ECG shows no evidence of ischemia, and it just shows a normal PR interval, just that the patient's bradycardic, okay? The answer in this particular, what I'm trying to tell you is that this patient is fine, okay? He is chilling in his chair. So all you need to do is just observe him and make sure he still continues to chill, and probably just send him home. You don't need to pace him because he's not got any adverse signs of needing to be paced. You don't need, you don't need to give adenosine because he's absolutely fine. And you don't need to do any of this stuff because he's fine. And DC cardioversion you do for tachys and not for bradys. My point being is that this patient's fine. You do not need to go in and be all crazy and interventionist, right? You're fine. So this is the algorithm for bradys. Basically, doctor ABCDE and find out if they're shocked. If they've got any adverse signs, sorry, that's what I should be saying, adverse signs. If they don't have any adverse signs, are they at risk of their heart stopping? The reason we go for bradycardias is that, I'm sorry, I lost my place. The reason we're worried, about bradycardias is because we're worried about the heart going to stop, right? The heart's going so slow that it's eventually going to stop doing so. But if they haven't got any, if they've not got any signs adverse signs that this patient's ill, then the next thing we're going to worry about is this patient at risk of potentially having their heart stop? I.e., do they have a recent asystole? Do they have Mobitz type 2 or a complete heart block, which I'll talk about a little bit later? Or do they have a ventricular pause of above 3 seconds? I.e., after a P interval, a P wave, does it take more than 3 seconds for the ventricles to react to that? If they do have any of these worrying signs, or they've got adverse signs, then we are going to give some atropine, which is I think it's a muscarinic acetylcholine blocker. Basically, what it does is that it blocks the parasympathetic drive. So you're basically just on your sympathetic drive. And the idea is to try and increase the sympathetic drive to get the heart beating a little bit quicker. So again, if they're all fine in all of these things, then you just need to chill out, and that's absolutely fine. If you're worried about it, then you'd give atropine, 500 micrograms every about 5 minutes or so, up to a maximum of 3 milligrams. And you would tell the patient that this is going to feel like absolute crap, because I think it's atropine. No, adenosine. I'm sorry. Before you give adenosine, it's going to feel like absolute crap. You need to warn the patient. Atropine, I don't know what it does. But yeah, you'd give atropine 500 micrograms every 5 minutes or so, up to a maximum of 3 milligrams. If that's not working, then you've got a few options. So transcutaneous pacing, which needs sedation, or giving something like isoprenaline or adrenaline. But as an F1, you're not going to go around giving this patient isoprenaline or adrenaline. As soon as you start getting worried, just to highlight to you guys, just in case you're worried about actually the whole thing about being a doctor, as an F1, you are expected to know fairly little, and you're expected to go and ask questions and to be bugging the med reg at every single opportunity. As soon as you see that this patient's bradycardic and they've got some funny signs, you do your A2E and then you call the med reg and you're like, I think this patient, and if it was me, I'd be like, right, I think that this patient's bradycardic. I think I need to give some atropine. And unless they're actually going to drop in front of me, I would call the med reg and be like, is this okay? Have I missed anything? And they'd be either yes or no. So yes, that's fine, give the atropine, or no, actually, you'd think about this as well. And then I'd go with what they say. So just a kind of like caveat in case you're worried about becoming an F1. So so that's just something to worry about, to just think about. But yeah, if they're fine, they're fine. If they're not so fine, then you give atropine up to a maximum of 3 milligrams. And then after that, you think about isoprenaline, adrenaline, or transcutaneous pacing to be able to try and kick that heart and get it moving again. All right. So causes of bradycardia, again, I nicked this from Adam Ali, shout out. Inferior MI because of the sinoatrial node, which we talked about a little bit earlier. Heart block. It's because it's taking a bit of time for the conduction to get through. If they're beta blockade or if they've got calcium channel blockers. So yeah, if they're on a beta blocker already, then you might be worried. Then they may have a heart rate of 40, and the reason why is just because you've given them too much beta blocker. Think about this with a septic patient who's got a heart rate of 64 when actually they should be 120. Why is that? It's probably because they've got a beta blocker on board, but there are some dodgy things like sick sinus syndrome, which can also cause these things. But just something to think about. Infections like infective endocarditis, rheumatoid fever, rheumatic fever, and typhoid, and some electrolyte imbalances. Or if they're a fit young person, because if you're fit like marathon runner level, or like Olympic athlete level, your heart is so strong that it only needs to beat like 30-40 times a minute in order to supply the entire body with blood. So that's the reason why they're bradycardic, which was the case in our particular patient. All right, so I just wanted to talk to you and give you a summary slide on heart blocks because it was a bit too long to tell you about everything. So this is, again, just a little cheat sheet, so take a picture if you need to. So heart block essentially means, what do we mean by heart block? Heart block essentially means that the conduction of the heart is being blocked by some particular method, all right? You've got different degrees of heart block. So first degree heart block is when it's taking a little bit of time for the signal to get from the atria to the AVN, or the AVN's holding on for that little bit longer than it usually would do. That means that a PR interval is above 200 milliseconds or 0.2 seconds, or one big square. And the real response to that is generally pretty chilling, unless there's anything else that's particularly worrying. If that's all that they've just got a first degree heart block and nothing else, then actually there's not a huge amount you need to do about that. That's absolutely fine. Second degree, or Mobitz type 1, is known as the Wenckebach phenomenon, and that's a gradually increasing PR interval until eventually you drop a beat, which is what it's like here. And usually that's nothing. You're not really that worried about it because it's not that dangerous. But again, if they're symptomatic, then you may need to consider things like pacing, as we talked about before, or the atropine, etc. If Mobit's type 2 heart block is worrying, so this is when you've got a fixed PR interval, but randomly you're going to be dropping QRSs. And this means that the heart conduction pathways are really, really screwed up, such that it's very, very rarely actually that the conduction is getting through to the ventricles and causing a proper contraction. And in these patients, they're usually symptomatic, and they're going to need a permanent pacemaker. Okay, so they're going to need to be paced for this. And then third degree heart block is, again, a worsening of all of this stuff, and they're going to require a pacemaker. Depending upon where exactly the block is occurring and which bit is taking over as the ventricular pacer, the QRS complex can either be narrow, as it is in this particular patient, or it can be a broad complex, because so if it's narrow, it means that it's coming from the junction, so just above the bundle. So you've still got that bundles acting as that sort of express highway to be able to conduct electricity very quickly to the ventricles. Or it could be a particular part of the ventricles itself taking over, in which case it's going to take a long time and it's going to have a broad QRS. The important thing, though, is that there's no relation between the P waves and no relation to with the QRS complexes. And you can also lose P waves within the QRS complexes, as is happening here. So it's the P wave happening very regularly at these particular intervals. And this one here is actually being lost within this QRS complex. Just something to be aware of. Okay. I've got a little chat thing that's come on. For exertional surgeries. Thanks, Mahesh. Brilliant. So bundle branches are another thing to just have a word with you guys about. So left bundle branch. So this is the classic William, where you have a W apparently in V1, which you can't really see here, and an M in V6, where you can see quite clearly. It's not that, and then the other one is a right bundle branch block, or a marrow, with an M here in V1, which you can see clearly, and the R, sorry, with the W here in V6, and that's your William and your marrow for left and right bundle branches. In reality, what I do is I cock my head over to the left, and if it's going to the left, then it's a left in V1, then it's a left bundle. If it's going to the right in V1, then it's a right bundle. But the thing with the right bundle is that you're going to have this RSR pattern. Otherwise, it's just a normal QRS, you see. So that's just something to bear in mind. Fine. So the ALS algorithm, right. So the ALS algorithm has changed because of COVID, and therefore I didn't think I should create a question on it because it's very quickly going to be wrong. I would recommend contacting your medical schools and seeing what they were expecting your particular things to be, all right? So I just wanted to highlight though just the differences between the pre-COVID and the COVID ALS algorithms. So the pre-COVID algorithm is that, okay, they've not got a pulse, they're not breathing, jump on the chest, then assess the rhythm, and then shock them if they're shockable, and don't shock them if they're not shockable. The difference with the COVID algorithm is that the first thing that you do is that you assess the rhythm. And after you've assessed the rhythm, you then decide whether it's shockable or non-shockable. If it's non-shockable, you're going to do the same thing as you do usually, CPR every 2 minutes, give some drugs, la la la. If it's shockable, then you're going to the first thing you're going to do is shock them up to 3 times. And then after that, you're going to continue the CPR pathway. On actual ALS, the way that you're taught it is that if you're the first person who's there, obviously you put the call out, then you kind of like make sure the bay is secure and no one else is getting in that bay. Get the defib, put the pads on so that you can assess the shock. You can assess if this patient needs to be shocked. In the meantime, the rest of your team will all get their level 3 PPE on board so that they can come in. And hopefully by the time you've assessed, and if you needed to, delivered 3 shocks, they're going to be in position ready to start CPR and doing the rest of it, in which time you will then move away and either get donned up yourself or act as the sort of gatekeeper to make sure nobody else who's not, fit tested and in the appropriate equipment makes it into that bay. So yeah, just check with your particular medical school as to how they're going to be testing it and if they're going to be testing it, because obviously it's very very contentious and stuff like that and topical. So SBA number 11. Okay, so a 65-year-old gentleman presents to A&E with a sudden onset shortness of breath and a reduced level of consciousness. On examination, you can see what appears to be a knife wound to his chest, but he refuses to give you any information about it. Funny that. You notice that the veins in his neck are distended, the heart rate is 127 and the blood pressure is 94/63. You're struggling to auscultate as the heart sounds very quiet. What is the best diagnostic tool? Chest X-ray, ECG, echo, or Doppler? I see a C, D, I see. I see. That's really interesting, Mahesh. I had no idea about that. That's really cool. So yeah, another reason why you need to ask your medical school. Okay, cool. So I see a lot of answers for C. Right. So again, I'm going to talk to the SBA. 65-year-old gentleman, doesn't really tell us a lot. Maybe a bit old. You know, as soon as I see 65, I'm like, okay, coming up into the elderly thing, heart attack, that sort of thing. Sudden onset shortness of breath. Okay, is this PE? Is this heart attack? Reduced level of consciousness. Okay, is this now a stroke or some weird clotting thing? On examination, you see a knife wound to the chest. Ah, okay, but he refuses to give you any information about it. Okay, now I understand what's happening. You notice that the veins in his neck are distended. Okay, his heart rate is 127, so his heart's beating quickly, but the blood pressure isn't managing to compensate for that, and you're struggling to auscultate. So this is known as Beck's triad, and it's classic for a classic presentation of a cardiac tamponade. And the way that you diagnose that is by using an echocardiogram. This is a Beck's triad. I thought this was a little bit, this is my own little silly joke. So Beck's, there's 3 of them. And the triad is this: the veins in the neck are distended, the blood pressure is really low, and the heart sounds are quiet. And we'll talk about why that's the case in the next slide. But essentially, a chest x-ray, you'd probably still do a chest x-ray if you could, but it wouldn't show, it wouldn't be diagnostic of the cardiac tamponade, because you're not going to get a great view of the fluid in the pericardial space, which is what you're looking for. But you may see a globular heart. An ECG may show something called electrical alternans, but again, it's not diagnostic as such. An echo is the investigation that you would need, and a Doppler ultrasound scan. So it's the right idea by using ultrasound, but a Doppler ultrasound is this, what we talk about when we are looking at the arteries in the leg for assessing for or assessing for a DVT and something like that. All right. So let's talk about tamponade. So basically, what's happening in tamponade is that fluid is getting into this pericardial space, which is the sac which is surrounding the heart. Usually it's blood, but it can be other fluid as well. But in this particular case, it's common. The classic example is someone's been stabbed. They've had a stab injury, which has gone through into the ventricle. The ventricle is now pouring out blood into this pericardial space. When it's doing that, it's pushing the pressure against this heart. So this heart is now struggling to be able to dilate because it's got all of this pressure outside it. And therefore, because it can't fill with blood very much, it can't pump as much blood around the body. So that's why the blood pressure is really low. In addition, it's getting congested with blood because it can't fill up with blood and move blood around, which is why you're getting the distension in the neck veins, and therefore you're getting the raised JVP, which is the second part of the triad. And finally, because this blood is building up into this pericardial space, you can't hear the heart sounds very well, which is the third part of the triad, and that's known as Beck's triad. Hypertension, raised JVP, muffled heart sounds. You can also get problems with the JVP as well as pulsus paradoxus, which is the way that the pulse differentiates with regards to breathing in. I can't remember exactly what that is, so if someone can clarify, that'll be fantastic. The other thing that I should mention as well is ECG changes. So the ECG, so the electrical alternans is this thing right here, where you see the peak, you see a big QRS and a small QRS, big QRS, small QRS, big QRS, small QRS. The reason why this is happening, so the reason why this is happening is because the heart is kind of swinging in the pericardial sac, and when it gets closer to the lead, the QRS complex gets a bit bigger, and when it gets further away from the lead, the QRS complex gets a little bit smaller because it's swinging around in this extra space that it's got in the pericardial sac. Okay, so that's electrical alternans, that's tamponade, and the management of that is urgent pericardiocentesis. So that's removal of that fluid in some way, shape, or form. And the way that they do it is either by a needle, pericardiocentesis, or they can literally pop the chest open and go in and scoop the blood out if it's something like that. And that's what people like HEMS are trained to do. Get a clamshell thoracostomy, open it up, and then start scooping blood out and suturing the bit of the ventricle as well. Quite dramatic, apparently. Not that I've seen it done in real life, but yeah, madness. So yeah, cool. Next question. Oh, what's this one? Oh yeah, a 50-year-old female presents with a 1-week history of chest pain, which is worse than breathing in and recent flu-like symptoms. On auscultation, you hear a squeaking sound, which is loudest at the left sternal border. Her medical history includes hypothyroidism and TB. How would you treat this patient? Watch and wait, NSAIDs and colchicine, urgent pericardiocentesis, or DC cardioversion? I see a B very quickly. B. All right. B. Yeah. So this, so again, let's go through it. 50-year-old female, fine. 1 week history. All right, so it's not acute chest pain. So it's not acute, but you know, it's chest pain. It's worse than breathing in. All right, so this sounds pleuritic in nature. And recent flu-like symptoms. Okay, automatically my SBA brain is thinking pericarditis, right? On auscultation, you hear a squeaking sound. That's confirming my diagnosis because I'm thinking, this is a pericardial rub. Loudest left central border, fine. And the past medical history includes hypothyroidism and TB, and that's a classic cause of pericarditis. How would you treat this patient? Would you wait a bit? Would you go for NSAIDs and colchicine? So the way that you treat pericarditis is by giving NSAIDs and colchicine. So pericarditis is inflammation of the pericardium. So you want to treat that by giving anti-inflammatories, which is what you've done. So well done. Watching and wait is just a bit is a bit brave. You need to treat it. You know what the diagnosis is. You should really be treating this. Urgent pericardiocentesis is even braver because you're not going to help anything. But it is a good idea to do an echo just to make sure there's not an effusion. And if there was an infusion, or if there was, if there was some sort of, if there's a pericardial effusion, or if there was a tamponade, then you need to do a pericardiocentesis in that particular case, but not just because of what you've got in this question. And DC cardioversion isn't really indication. It indicates there's no signs of any arrhythmia or anything like that. All right. So let's talk about pericarditis. So causes. So again, this is just a list, I'm afraid. Viral infections, classically Coxsackie virus, TB, uremia. So think about this in patients who've got renal failure. They can't excrete urea very well, so urea builds up and therefore can cause a pericarditis. Post-MI, so this is the Dressler syndrome like we talked about before. Connective tissue disease, hypothyroidism, and malignancy. And because the malignant cells are seeding themselves in the pericardium and causing inflammation. Pericarditis acutely presents with pleuritic chest pain, improved by sitting forwards, dry cough, flu-like symptoms, the rub that you can hear, as well as potentially shortness of breath as well. The classic ECG sign, constricted pericarditis. Okay. If you've got a lot of inflammation, then you would have fibrosis building up, and therefore you can get this constrictive picture because you don't have the relaxation that usually occurs. So you can get heart failure, raised JVP, and Cushman sign and loud S3. So, that's wrong actually. It should be diagnosed with ECG and history. I'm sorry, that wasn't changed. And plus an echo to check if for effusion. All right. So the ECG that you would see is this classic saddle-shaped ST elevation and potentially a reduced PR interval as well, or a depressed PR interval. And that the thing is that you wouldn't just see that on V5, you would see that on V6, V1, AVL, and 1. And so it's this global ST elevation, and the saddle-shaped appearance is classic of pericarditis. All right. Okay, coming up, we're close to the end. So 75-year-old gentleman with a history of hypertension and ischemic heart disease presents to A&E with increasing breathlessness. Says this has come on over the last 4 weeks and has noticed both legs swelling up and he needs 3 pillows at night to sleep. He has fine crackles on both bases with pitting edema to the mid-calf. His observations are as follows: heart rate, respiratory rate 24, BP 112, heart rate 90, temperature 37, oxygen 95. Given the most likely diagnosis, what's the best initial management for this patient? IV furosemide, glycerol trinitrate, position the patient upright, IV diamorphine or high flow oxygen. Why the colchicine? It's an anti-inflammatory. Exactly the mechanism in all pericarditis, I'm not sure, but yeah. The answers generally, the consensus is A. I think you're absolutely correct. So again, let's go through it. Ischemic heart disease, risk factor for heart failure, increasing breathlessness. Okay, hypertension, ischemic heart disease. So this patient's got some cardiac problems. He's got breathlessness. So immediately I'm linking these two things together and I'm thinking this is probably cardiac related breathlessness. Come on over the last 4 weeks, so it's taken its time, and he's noticed both legs are swelling up, and this is classic of right-sided heart failure. He needs 3 pillows to sleep at night because his lungs are getting wet at night when he's trying to lie down. So the water is going everywhere in the lung. So he needs pillows to kind of make the water go down and able to ventilate the top part of his lung and actually be able to breathe. So this is left-sided heart failure signs. Fine crackles on both bases with pitting edema to the mid-calf. Again, just confirming that his lungs are wet and the legs are wet. His observations are as follows. So he's actually maintaining his oxygen saturations. Blood pressure is actually all right. And because of that, and basically this patient's fluid overloaded, the heart's failing, the patient's effectively fluid overloaded. So you need to give some IV furosemide in order to provide symptomatic relief and therefore treat the patient. So that should actually be highlighted there, guys. Sorry about that. GTN spray positioning the patient is definitely a good idea, but it's not actually the best thing because actually the furosemide is what's going to treat this patient, but you would definitely position the patient upright. Diamorphine and GTN can be considered, and high flow oxygen is not needed in this patient because actually they're maintaining their oxygen saturations. All right. So let's talk about heart failure. So the definition of heart failure is when the heart's not pumping enough blood to supply the body's demands. I see a quick question up here. Brilliant, so we've got an answer. It's not pumping enough blood to supply the body's demands. All right. So another definition that we need to know about is this thing called ejection fraction, and it's a proportion of blood which is ejected usually from the left ventricle per heartbeat, and it's measured as a percentage. So if the left ventricle usually fills up with 100 milliliters of blood, and when it contracts, it pushes out 60 milliliters, then that's an ejection fraction of 60% because that's 60 over 100. But if it only pushes out 40 milliliters, then now it's an ejection fraction of 40%. And actually, we want our ejection fractions to be about 50 to 70% as normal. All right. So systolic, there's types of heart failure we can divide into various different ways, but one of the ways is to look at systolic and diastolic. Systolic means heart failure. Systolic means that during contraction, the heart is not able to push out as much blood as it should be able to. So that's heart. So because of that, the ejection fraction is reduced, and therefore this is known as heart failure with reduced ejection fraction. All right. So this is usually a heart failure with an ejection fraction of below 50%. Causes of this is things that can cause problems with the heart muscle, so ischemic heart disease or cardiomyopathies, for example. Diastolic heart failure is when the ejection fraction is maintained, but still the amount of blood coming out of the heart isn't enough. And usually that's because the heart can't fill up with enough blood to be able to, when it contracts, supply the rest of the body. So for example, if you've got constrictive pericarditis, so that the heart muscle can't relax properly to accommodate all the blood that it needs to accommodate, or if you, for example, have a massive tumor or something which is growing within the wall, then in those particular, the ventricle can't fill up with enough blood to then be able to pump itself out, to pump all that blood out and supply the body. So say instead of 100 milliliters, you can only pump out, you only fill up with about 50 milliliters, and you're still able to pump out 40 of those milliliters. Now you've got an ejection fraction of 80% because that's 40 over 50, but still it's not enough because it's only 40 milliliters of blood. And hypothetically, that's not enough to supply this particular patient. So the ejection fraction is maintained, but it's still the heart isn't pumping enough blood to supply the body, so you're still in heart failure. And this is known as heart failure with preserved ejection fraction. So systolic heart failure is reduced ejection fraction, or HFrEF. That's a problem with the heart not contracting enough, and that's because the muscles are screwed up in some way, shape, or form. And diastolic heart failure is when the heart doesn't fill up with enough blood in diastole. The ejection fraction is maintained or preserved, and the causes of that include constrictive pericarditis or restrictive cardiomyopathy, for example. So the clinical features are easiest to break this down into left-sided heart failure and right-sided heart failure. So I think that most people actually were aware of how these present, but just in case you weren't, think about the way that the blood flow goes around the heart, yeah? It goes from the left ventricle, around the body, into the right, from the left side of the heart, around the body, to the right side of the heart, to the lungs, and then back into the left side of the heart. If the left ventricle fails, then effectively you've got a blockage here, and then you've got a build-up of blood and water into the capillaries. So that's what's presenting with wet lungs, shortness of breath, waking up, gasping for breath, a wheeze as well, and a classically pink, frothy sputum, all right? So that's your left ventricular failure. Right ventricular failure is when you've got a blockage here, and then all of this stuff in the body is blocked up. And then you've got the peripheral edema, raised JVP, or even ascites and things like that. So the rest of the body is all covered in fluid. So that's how you can divide up left-sided or right-sided heart failure. And congestive is just both, when you've got wet lungs and you've got wet legs. All right. SBA 14, so a 66-year-old patient with known systolic heart failure comes into the GP surgery, states that he's recently started to get more breathless than usual, not breathless at rest, but gets breathless when he's changing his clothes or walking to the kitchen. How severe is his heart failure according to the New York Heart Association classification system? 1, 2, 3, 4, or 5? Okay, good. So I see that most people have gone for C, which is the correct answer. So this patient's got known heart failure. He's not breathless at rest, but he's breathless when he's changing his clothes or walking to the kitchen. So he's fine at rest and able to, but as soon as he starts getting up, then he starts getting breathless. And this is your NYHA class 3, okay? So New York Heart Association classification systems is split up into, it's split up into 4 different classifications. You've got number 1, where they're absolutely fine, they're able to jump up the stairs and they're absolutely chilling around and doing, doing their general activities. They've got heart failure apparently, but actually they're absolutely right. Stage 2 is breathlessness during normal activities, i.e., so if they're trying to climb the stairs or do whatever, then actually that's it causes them a little bit of breathlessness. But when they're just, if they they can, when they find that are at rest, and they're fine when they get up and just have a little bit of a toddle. If when they get up and have a bit of a toddle around, they start getting breathless, then now it's NYH class 3, as long as they stay fine when they're at rest. But if they're breathless even at rest, then that's NYHA class 4. And class 5 are just made up, just in case you guys didn't know what it was, and just to catch some people out, which it sounds like it probably did. So that's all that. Again, it's a really easy question to bring into an exam, so it's worth just knowing. So investigations in terms of heart failure. So first of all, always think about it in terms of bedside investigations, bloods, imaging, and other stuff as well, right? The bloods that you would be doing is the NT-proBNP. Ignore BNP, we don't really use it anymore, we use this one instead. If the levels are high, or say this patient came into the GP surgery, if the levels are high or above 2000, we'd be doing an echocardiogram to be able to confirm heart failure within 2 weeks, because we're a bit more worried. If it's just raised, so a little bit up, but not too concerning, then we're going to be doing it in 6 weeks, because we're not as worried about this particular patient. The imaging choice modality is to diagnose heart failure is going to be a transthoracic echo, because that's going to take a look at the ventricle specifically, tell you how much blood is coming out with each contraction, and actually give you that diagnosis really, really well. But you can also have particular settings that come up, you also have particular findings that will come up on a chest x-ray as well, which is known as your ABCDE of heart failure. So your A is the alveolar edema, which is like this sort of fluffiness coming up at the sides because of the blood and fluid leaking into the interstitial spaces, or that's also known as bat winging. The B is these curly B lines, which apparently exist, and I think there's one there, and this is fluid building up again into that interstitial space, and which you can then see as a line. C is cardiomegaly, or a big heart, because the heart's having to maybe fill up with more blood, or it's struggling to contract, and it just gets maybe potentially bigger. Doesn't always happen, but this is like in severe heart failure. Dilated prominent upper lobe vessels. So this is so the reason why this happens is because if the patient is in heart failure and left-sided heart failure, then the lungs will start filling up with fluid, right? And gravity will push that fluid down as long as they're sitting up, because the lungs know that the bottom part of it is filled with fluid and is not going to get any oxygen. It's going to divert blood to the upper lobes in order to be able to ventilate them. You can actually see this on the chest x-ray. And the final thing as well is pleural effusion. So fluid building up into the pleural spaces, seen by blunting of the cross-phrenic angles. I would say that an NT-proBNP as an inpatient, if you're worried about this patient's got heart failure, you're not going to faff around for 2 weeks or anything like that. You're going to do an NT-proBNP immediately to try and see whether that's a diagnosis that's actually relevant in this patient. And then you're going to get an inpatient echocardiogram to try and diagnose it if that's giving you a sign. You would do, and the other thing as well, the most important investigation that you're going to do is daily weights if they're an inpatient, because you're going to give this patient furosemide to try and get the fluid off, and you need to make sure that furosemide is working. So they must be weighed daily. And if there's an SBA that comes up with the most important investigation that an inpatient needs in heart failure, and it says daily weights, you pick daily weights, because that's the thing that all the cardiologists are asking for on a regular basis. All right. So that is investigations. Management of acute heart failure. So you do your Dr. ABCDE, and then the Dr. ABCDE, and I learned it as LMNOP. So you do all of this stuff, and because obviously guidelines have changed, it's actually just LOP. So loop diuretics is the IV furosemide to get that fluid off, and that makes a lot of sense. You can also give morphine and nitrates to help venodilate, and just increase blood supply to the heart, but also just allow the lung vasculature to relax, and therefore reduce the amount of the pressure that the heart needs to overcome in order to supply that particular tissue with blood. But it's not a routine thing anymore, and definitely nitrates, if they're hypertensive, we wouldn't be giving them. And that's stuff that I just learned in this particular year from when I reread the guidelines and made the lecture. Oxygen, if the oxygen is needed, and that makes a lot of sense. And then P for position, and position them upright and let gravity help you. And that's really important. And you can just try to illustrate that by these set of x-rays. So this is a patient and they were lying down, and this is a patient and they were sitting up. And you can see how the fluid shift is so much improved. The way that the lung is ventilating is so much more improved when the patient's actually sitting up, because all of that fluid is now going to the bottom, and I can actually ventilate this part of the lung, which is why position is definitely recommended in these patients, right? If none of these things is working, then you need to obviously step up. And you're thinking about CPAP, which is continuous positive alveolar pressure, i.e. putting a mask on their face, which is blasting air into them. And what that does is that splints open the alveoli and it pushes that fluid into the capillaries where it's meant to be, rather than into everything else. And then you can consider things like inotropes and ultrafiltration as well. But really, Dr. ABCDE, LMNOP, maybe ignore the M and the N. All right? So that's what you need to do. Most important things, the furosemide and the position, I would say. And obviously, if they're hypoxic, give them oxygen. And then this is a big, long, busy slide on management of chronic heart failure. So the main thing you will need to worry about is HFrEF, so systolic heart failure. And the things that are going to improve prognosis, which is an important thing to know, is an ACE inhibitor and a beta blocker. And the second line is going to be your spironolactone, all right, or a planorenone as well. Just a point here that the NICE guideline can get really complex. I would recommend just sticking to what Passman tells you, because that's the stuff that you actually need to know and is digestible. But essentially, first line ACE inhibitor and beta blocker, second line is the spironolactone or the planorenone. The third line treatment depends really upon what exactly it is that it wouldn't be you, it would be a cardiologist, and it would be, and that kind of depends upon what the patient's like and what would help benefit that particular patient. If the patient's got atrial fibrillation at the same time, digoxin's quite good, because as well as controlling it's a chronotropic effect, so it makes the heart contract a little bit harder, but it also is an antiarrhythmic, so it can help to, put them into a more beneficial heart rhythm. If they're Afro-Caribbean, then they could have things like hydralazine and nitrates. There's good evidence in that particular group. If they're symptomatic on ACE inhibitors, on ARBs, then there's this particular medication which can be used instead. And there's also ivabradine, which is another fourth line option that cardiologists can take a pick of and choose. If none of this stuff is working, then you're going to go for the surgical option, which are the implantable cardiac defibrillators, or your cardiac resynchronization therapies, resynchronization devices. And the reason why you would give this is because as the heart failure is progressing, you have a risk of QRS widening and PR progression, and actually arrhythmias developing. So you want to be able to give something that if they were to go into a shockable rhythm and lose their output, then they would have a shock to then reset them into a normal way, which is the implantable cardiac defibrillator. You can also have the cardiac resynchronization device, which is essentially leads around the heart to help the ventricles contract in a concordant way, as opposed to just letting them contract and doing some random wishy-washy stuff as they would do if the heart's just failing and getting weaker and weaker and weaker. So it's just about trying to save that pretty much dying, screwed up heart. So really, ACE inhibitor and beta blocker, spironolactone, those are the three that you're going to give in most patients. After that, it's a specialist decision, but if they've got AF, you're probably going to give digoxin. And then after that, it's a surgical options. There's a real take-home message just from that particular slide. If they've got HFpEF, then really there's nothing specific mentioned on the NICE guidelines as far as I could see. It's really loop diuretics for symptoms, and that's it. The other stuff that you need to know about as well is an annual influenza vaccine and a one-off pneumococcal vaccine as well that you would give to these particular patients. I would add as well that in patients who've got systolic heart failure, they may be on regular furosemide, but the key SBA point is that that's not necessarily got evidence, but is very good for symptoms. And the only reason that they can say that is because they did the trials with ACE inhibitor, beta blocker, and Spiro. They didn't do the trials with furosemide, but everyone uses furosemide because it makes the patients feel better because you're getting the fluid off. So even though it's not got prognostic benefit giving furosemide, it's actually better for you in general.